All right, good morning, everybody. Welcome to Denver. This is always one of my favorite conferences of the year, and I am Tim Henry, and I am the director of the Lindner Center at Cincinnati, and this is my co-moderator, John Messenger from University of Colorado, and this is going to be a fascinating session, and our panelists are, well, now I got to add them up there, Mazen, Abu-Fadel, Lorenzo, Azzalini, Mauricio, Cohen, Yader, Sandoval, Jeff Schussler, and Arnold Cito. And what we're going to do is a series of cases followed by algorithms of how you treat that. And so I think this, personally, I'm looking forward to it. Our first speaker is going to talk about why did the vessel close, and this is Ashish Pershad.
We're going to have you down here in front, Ashish. Oh, yeah. The circle of trust.
So we're changing the format this year. It will be TED style. They'll be on the floor, close to you guys, so feel free to reach out to them before, during, or after. So thanks, Ashish.
Yeah. Again, thanks for, I echo Tim's sentiments. This is truly an operator's enclave. I agree with that, and I love the interaction, and I also enjoy the fact that we're going to have an interactive 8 minutes of discussion, and I'm hopefully everybody's going to get something out of this. So the case that I'm going to talk about is the case of an abrupt vessel closure and then the downstream consequences of that. So here's the story. This is a 78-year-old gentleman who has pretty activity-limiting angina and significant quality of life impairment. He's had a CABG after an ACS where he got a lemur to the LAD and he got an atrial clip on his appendage. And he's on 2 anginal agents and he's pretty miserable right now. So as we've become sort of going to pre-procedural CT planning on most cases, and so here's what we're dealing with. As you can see, he's got a very, very calcific left main and circ OM system. His LAD is bypassed, so it's really not anything to be concerned about. His right had non-flow limiting disease. His EF was normal. So this was sort of very interesting to me because obviously we look at the CT, and then when we look at the angiogram, it's kind of weird how underwhelming the angiogram is as compared to how aggressively calcific and how nasty the vessel looked. So a quick comment about this atrocure, which basically lines up perfectly at the circ ostium, and so it was really hard to get a good visualization of the lesion, number one, because the left main, as you can see, was heavily calcified and very tortuous, and that OM branch was quite difficult to separate. So we did the usual. We saw the significant amount of calcium. We imaged, and then we ended up rotoing down the AV groove circ and then ballooning it. And what you have here is a balloon in that AV groove circ with full expansion. Comments thus far from the panel about using atherectomy, protection of the side branch, using a guide extension or some sort of therapy to be able to have 2 wires. So any comments?
I personally, after atherectomy, would have wired that large OM, but that's obviously not necessary unless you think you're going to do something there. So I personally would have had 2 wires there.
And I think that's the point. That's a very important point, which will come back to haunt us later. Any other questions about? I kind of got a little cavalier because I thought the vessel was although would not be so challenging to wire. But you're right. That would be option. A safe approach for operators early on is to wire both branches and then balloon. Any other questions and comments, Lorenzo, at this point?
Well, you said you did a atherectomy before, so of course you cannot leave a second wire there. Honestly, from this image, it's hard to see, but I don't see any significant lesion on the marginal. So, I mean, you can make a point. I mean, at the ostium I'm talking.
Oh, at the ostium of the OM. Okay.
Yeah. So your wire and balloon are in the circumflex here?
Yes.
Okay. Yeah, there is a lesion a little bit downstream.
Yeah.
I mean, in hindsight, discourse, we can say that you should have protected the marginal, but I don't see major issues so far. So it's not unreasonable not to wire it, I think, at this point, if there is no clear lesion of the ostium.
And satisfied with the expansion of the balloon, Mauricio and Tim?
But if you're going to use the pre-CTA,
Yeah.
doesn't the pre-CTA show you should protect the marginal?
I think more than it surely does. Not only does it tell you to protect the marginal, but also I think the angle between that OM and the circ dictates that you probably should. I mean, I think this is a little bit, I think, an error on my part of just being a little cavalier.
With the side branch, I think that intravascular lithotripsy would be very tempting to protect the side branch and keep both wires.
Got it. Yeah, that's an option.
I think it's okay. I mean, you have a little bit of lumen. I mean,
Yeah.
I mean, the left atrial occluder is covered.
you've got
there.
it
You
perfectly.
should probably get a better view there.
Yeah.
Yeah.
But it looks okay. I mean, you can go back in. That's my impression.
Yeah, so what ended up happening is, of course, we post-dilated and potted and had to get the left main treated with a 4-5 NC, and then this is what we got. So now we have a problem. The entire big OM is plastered, shut. And the patient's sort of sick, feeling a little vagal, bradycardic, blood pressure sort of looks nauseated, doesn't feel right. And the EKG on the width hemodynamic profile shows that he has some deep ST depressions. So that OM is sort of an important vessel, and he's feeling it.
Certainly trying to image it better by moving, trying to see where you have an entry into the OM would be important, I think, here, if you're going to try to recanalize that.
Yeah, so CTO operators, other people here, how would you guys, at this point, what wire, what microcatheter, what balloon, how would you access that, and what would be your order of business?
Well, I think here the problem is also due to the fact that there is a lot of calcium around there. So not only you dilate it, but you also put a stent. I think that simple workhorse wire will not have an easy time accessing that side branch. So also due to the urgency of the situation that the patient is decompensating, I would go for a polymer jacket intermediate, tip-load polymer jacketed wire like a Gladius, something like that, to just try to navigate through the tissue plane with the calcium into this occluded side branch.
And microcatheter choice?
Yeah, I mean, you can make an argument. You can use a dual lumen catheter. It's gonna be a little bit easier to wire, but then you have to trap it out and go with a regular microcatheter. So then you waste some time there, or you can go directly. I mean, I think there's no dogma here. You can go with either.
Yeah, so I thought the calcific segment, I went with a turnpike spiral, and then, as you rightly pointed out, I first tried a Pilot 200, and then quickly transitioned to a Gladius Mongo. So 4.5
If anyone wants to make any questions from the audience, have the microphone here. So anyone who wants, just raise your hand. I'll come right
please
to you.
feel free. Sorry, I didn't just mean to ignore you guys in the audience, but so anyway, so it was a little bit of a difficult wire, and you can see that the Gladius Mongo, and finally we were able to switch out and ballooned, and then here's what we got. What's going on the right panel, folks?
There's obviously a pericardial effusion or something there. I don't know. Something's filling next to the AV
coronary
groove, sir.
sinus.
Or coronary sinus filling quickly. There may be like AV.
Yeah, so
something's there.
so pericardial effusion post-cabbage, possible, but not to be that free-flowing, right? I mean, so that's a
Yeah, I mean, it's possible. Manos always shows us that nice one that he had with
Yeah,
the
yeah,
patient.
no, there's-
I mean, it's possible, obviously, but not.
Any other thoughts from the people in the room? Where is that going? What's going on there? The patient's actually, once this happened and I ballooned, he started complaining of more chest pain.
So Ashish, how difficult was it getting in there? Did you use a microcatheter? It took some time?
So there were some transgressions with the Pilot 200 before, and not really easy to navigate in the beginning. So I clearly had some, I would say, transgressions with the wire, but not the microcatheter. Ultimately, the knuckle went straight down distally, and the Mongo was able to. Hey, Tony, how are you?
So how is the patient doing?
He's stable, but he's not well. I mean, he's hemodynamically stable. He's got a patent
Blood
lead.
pressure is not dropping.
Blood pressure is not dropping.
You're
Heart
not
rate.
worried about impending tamponade.
Is it impending tamponade? I mean, that's the question, right? That's a big question. So
When he's not well, you mean ischemic or
Ischemic.
hypotensive?
ischemic and complaining, nauseated, Zofran's in, fluids are going wide open, blood pressure is in the 90s, heart rate is 40.
Just a quick question for you. After, is this washing away or is it staying there? Because we don't see the cine is not long enough.
It's going away.
It's washing away. So it's open to some kind of vessel or ventricle or atrium or something. At least
So
we
I mean,
know
if you
that.
follow the dogma of disappearing, contrast is
Disappearing
worse
somewhere,
than
yeah.
is worse than a stain.
That's why I'm asking. 'Cause,
Yeah,
so it's not a localized hematoma.
Yeah.
It's definitely open to some cavity or
So,
vessel.
so if we don't understand what's going on, there is some vessel injury, I would just blow up a balloon again into that branch to gain time and try to think what's going on. If it's a perforation, it's going to seal. There's also the vessel is completely dissected proximally, so it's going to for sure improve to some degree.
So
And call the echo tech.
so there was no effusion, and so there was no effusion. We did do that, and of course we treated the proximal vessel, but as you can see, it was a type 4 perforation into the coronary sinus, and even after treating that proximal dissection and a prolonged balloon inflation, there still continued to be extravasation into that sinus. Patient did continue to have symptoms of chest pain. And I just didn't feel comfortable leaving it, even though it was clearly, in my opinion, a cavity spilling type 4 perforation. So I used a papyrus and we covered it, and it was instant because the minute the perf into the sinus was covered, he felt better, the symptoms resolved, blood pressure was good. And so I think the takeaway for me was prophylactic protection of the side branch when treating is important. Plaque shift can occasionally cause abrupt vessel closure. And a type 4 perforation into cavities, in this case the sinus, are not always asymptomatic and may need treatment with a covered stent in about a quarter of the cases. Thank you.
Terrific. Thanks. Yeah. Thank you very much. Hopefully we'll have a few minutes for discussion. Dr. Ijioma from Ohio State University is going to share with us an algorithm for dissection management. So thank you very much.
Okay. All right, everyone, good morning. So my name is Nkechinyerei. I'm an interventional cardiologist at The Ohio State University, and I'm going to give you a case presentation, iatrogenic coronary dissection, the treatment algorithm, and I have no disclosures. So here's our case. We have a 70-year-old man who presents with exertional chest pain. He has a history of hypertension, hyperlipidemia, and prior nicotine dependence. His vitals and presentation to ED, he's stable. His blood pressure is 111/76, heart rate of 52, and his respir is about 18 breaths per minute. His labs are significant for slightly elevated troponins. LDL is 103 milligrams per deciliter. And here's his EKG. You can see he has sinus bradycardia. And look at leads 2, 3, and AVF, this ST elevation. So he's diagnosed with acute inferior STEMI. The cath lab was activated. He was given aspirin 324, IV heparin bolus, and ticagrelor 180 milligrams. And here is his coronary angiogram images. Initially we tried to go through the right radial artery, but he had severe spasm of that right radial artery as well as a tortuous arch, so we aborted the radial artery and went to right femoral. And then you can see here his images on the left, the far left and the middle panel shows left coronary system. He has really diffuse disease in both the circumflex and the LAD. There's about 70% stenosis in the circumflex, and there's about 50% stenosis in the mid-LAD and 90% in the diagonal. And look at the far right, he has a 95% stenosis in the mid-RCA. So given his clinical presentation, this was thought, the RCA lesion was thought to be the culprit, and so we proceeded to do PCI. And some questions for the, what guide catheter would you consider using in this tortuous RCA?
Can you show the EKG one more time real quick?
Yeah, absolutely.
I think these are always challenging, particularly when you find the mid-circumflex stenosis in these infra-posterior MIs, and whether or not that's also a lesion. But usually, I think I would use something that's, an AR mod or, AL.75, something. This is not going to be simple to wire this, so I don't know if others have other thoughts.
Just if you can show the angiogram again, and I totally agree, something with a little extra backup, but I've started using more guide extended catheters even in my non-radial, just because I knew navigating that proximal right's going to be challenging.
Okay. Do you have a question?
It's inferior STEMI for sure. You have to fix the right, and then I think you have to decide, see how well that goes and then take a second look on the left. It complicates it when you have radial spasm with this. Especially, this is a tortuous right, and it might be challenging for sure.
Yeah. So go ahead.
Thank you. Great case. I know it's an intervention meeting, and we are interventionists. We want to stent, and it's a STEMI. We have to do it. More than probably, 120 STEMIs I've done so far as a faculty. Probably for 2 cases, I decided to send them for bypass, and they both did fine. This case, with all the amount, tortuosity, calcification, the lesion on the LAD, mid to distal, I think is even more than 50%. And I don't know the prototype of the patient, how stable she is. Do you think would be somebody, and you have a T3 flow in RCA. It's not like you don't have a T3 flow. Did you ever thought about maybe a balloon pump temporizing, talk with the surgeon? I don't know. Just bring it up as an option.
Yeah, you raised very good points about considering bypass. He was stable at the time he presented to us, and the thought was we could just treat the RCA, and then we could then send him up. This was one of our smaller hospitals, and then send him off to the main campus for the left LAD revascularization. Any other comments, or should I go on? Okay, so we decided to use for the far left image there, you can see the still frame. We initially tried an AL.75 guide, but that kept getting sucked in, so we swapped out for an AR1 guide catheter, and we got a BMW wire across the lesion. We ballooned it with a 2.5 balloon, and then stented that with a 3.0 drug-eluting stent. And then that middle image there, you see our post-stent image. Wire out shot. You can see that the AR guide is deeply seated in there, but we have TIMI3 flow in the distal vessel. And as we took one more final picture there, you can see at the proximal RCA there's a dissection, and we no longer have TIMI3 flow in the distal vessel. So what do you guys want to think about? In addition to now getting a new wire down the vessel, what would you do next?
I think the panel here probably would vote for intravascular imaging, at some point to figure out how far back you're going to need to stent, because the suspicion is that this is dissected from your mid-RCA stent back to the proximal segment. So I would do that, but I'm assuming that wasn't done prior to dewiring. So.
No. You're about to say something.
Yeah, well, I think that, you assume that you're going to rewire that dissection, but I wouldn't assume so. That's a very complex dissection. And you may not, I'm always afraid that I may never get in the true lumen. So I think that you can have a moment to think about once you rewire. Now you're more quiet. And you can open that with a balloon. You can stick and stabilize the patient first. So that's what I would do. I think I was always reasonable.
For me, for me, it depends how the patient's doing. You have hardly TIMI1 flow after the dissection, after the wire's out. If the patient's very sick, you obviously want to try safely get a wire down, at least as Mauricio said, I agree, maybe balloon it to get better flow. Then if you want to take the time to IVIS it, you can. I probably would not mess with IVISing it if the patient is unstable and the flow is that bad. That's how I would approach this, at least.
Well, the good news is that the dissection cannot extend further because you stented the mid. So you know that 99.9% of the cases you will be able to get out of this situation without losing the entire RCA. I agree with the previous comment that wiring might not be so trivial. But then, you probably need to put a stent there because there is extensive hematoma. So I think that, to stabilize the patient, you can inflate a balloon and squish the hematoma a bit and open it up. But for sure, imaging is very important to choose the right stent. You don't want to create a second problem by putting a 2.5 stent in a 5.0 vessel or something like that, right?
All right, so we've heard from the panelists, imaging is important, and then you also want to think about when you get the wire down, making sure that you sometimes use a balloon to just tack the dissection flap and then consider whether or not you want to put a stent. So in the last couple of minutes, we did do a drug-eluting stent placement. What we did was, because we no longer had the wire down, we decided to swap out for our AR guide for a less aggressive guide, a JR guide, and then that kind of helps us to redirect our, realign things a little bit to get the wire down. Initially, when we tried to get the BMW wire down, we got into the false lumen, and so we parked that first wire there, and then went in with over the wire balloon, and then with the second wire, that kind of helped us to limit our just little puffs as we used the over-wire balloon, and then got our wire into the true lumen. Once we got the wire down to the true lumen, we used the over-wired balloon, ballooned it a little bit, and then put two overlapping drug-eluting stents across that proximal RCA. And then we, you can see our final image there. We post-dilated the stents, and we had good TIMI3 flow there. So in the, I just want to go over an algorithm. So it's important for us to recognize dissections, coronary dissections when they occur. For your reference, this is the NHLBI classification. There are 6 types, types A through type F, where type F is total occlusion of the vessel. When you have a patient that presents in the coronary artery, you always want to be thinking, what are the risk factors? And these can be classified as either technical, angiographic, or a clinical presentation of the patient. So angiographic things to think about when you have a patient that has calcified lesions, eccentric lesions, these are at high risk for coronary dissections. For technical things, we had mentioned the guide catheter. If you have an aggressive guide, so AL1s, you want to be careful with those as well as AR guides. And then also, if you deep throat your catheter, you want to always be careful about that, causing dissections. Other things to think about from technical issues, when you're doing your contrast injections, always want to be careful that you don't have a dampened waveform when you inject, because that can cause dissections. And then you also want to think about your wire techniques as you advance your guide wire in. Other things to think about, the balloon angioplasty. Balloon, if you use an oversized balloon for your vessel, and that can cause a balloon rupture and dissect the vessel as well as your stents. And also guide liners can also do this as well if you don't have good techniques when you advance your guide liner. And finally, studies have shown that patients with acute coronary syndrome are high risk for dissections compared to chronic coronary syndrome patients. Here's a little treatment algorithm for you. I think this is the key point of this talk. If you have a coronary dissection, and the first question is, do you have a wire down or not? If you have a wire down, you can just go ahead and decide whether or not you want to stent it. When you want to stent that vessel, you want to think about stenting the entry point of the dissection flap first, and then you can then go ahead and stent the distal portion of it. If you don't have a wire down, then your first question is, someone mentioned here, is are you able to wire the vessel? If you're able to wire the vessel, you want to think about either changing your guide catheter, because sometimes that can help you redirect away from the flap. And if you can't still get your, and then also consider IVUS once you get your wire down. If you can't wire the vessel, then what someone had pointed out, if they're unstable, consider bypass surgery. If the vessel is small, you may just manage that conservatively. So do's and don'ts, always try to stent the entry of the dissection flap first. Try and think about longer stents to cover the entire dissection, and then post-stent IVUS. Limit your contrast injections, be careful about your wire techniques, and avoid aggressive stent post-dilatation, because that can propagate the hematoma. And I will end here because we're over time. Thank you so much.
So Nkechi, I think we have a few more minutes. Maybe a couple of thoughts. For me, the key thing, right, is how do you get the wire down? So I don't know, maybe Yader, what are your thoughts? You have this happen, and now you don't have wire. What do you do?
Yeah, a couple of thoughts. One is at the beginning, in a tortuous vessel like this, and it seems like maybe wire was lost a couple of times. I think I have a low bar to bring a microcatheter and switch like for a wiggle and have a supportive wire in addition to a supportive guide, not to lose it. Now, if you lose it, then I think you have to come also have a low threshold for microcatheters. And I mean, sometimes, to be honest, you even have to put a CTO toolkit, and sometimes you can't see distally where you are. You need a contralateral view, and there's different approaches to see whether you're in true lumen than to confirm.
Quick question. Did you think it was the edge dissection from the stent or from the guide catheter? And the second question was, did you stent all the way back to the ostium? I didn't see on the slide.
Thank you. We thought it was due to the guide catheter. Remember, if you look at the second picture, we're kind of deep-throated in there. And so I think being deep-throated and giving contrast, that dissected it. In terms of the stenting, we stented just at the ostium, not far into the, I think we have another talk later today about aorto.
But from the stent all the way back?
Yeah.
Okay.
Okay.
Yeah, I think one of the things about that strategy is stenting proximally can be helpful in tacking this up, but in severe tortuosity, it can sometimes preclude you from delivering stents subsequently distally. So you do need to think about a guide extension or something like that. So, any other comments from our panel? We've got a minute or two before
I think a dual lumen catheter in a situation like this, which was not mentioned. I think she used the old-fashioned over-the-wire strategy with an over-the-wire balloon, but sometimes if the BMW goes into the false channel like it did, which it probably will because it follows the previous path, but if you just leave that in place, get a dual lumen, especially the IMDS recross, is really helpful because they're both over-the-wire paths, and you can easily use either a penetrated polymer jacketed wire to get back in, like a Pilot 200 or even a Xi'an Black, and then you'll be able to withdraw them both fairly easily, because as it gets challenging with the other dual lumen catheters, when one is over the wire and one is monorail, you could lose them. So this is another trick.
All right.
Very quick, sorry, about dual lumen. I was about to add the comment on that we had a case recently, one of our junior faculty used a dual lumen and couldn't get to the true lumen. So sometimes it can be, as you said, very tricky to use a dual lumen to be able to get. So you might be able to just free wire it with a, a single lumen catheter.
Great.
But if you do, then your last strategy is to go in with a Stingray. I mean, that's your last approach.
All right.
All right, so thank you very much. Fascinating case. Our next case is Tim Mixon is going to talk to us about thrombosis and embolization treatment algorithm.
Okay, good morning. Thank you very much for the opportunity to present. I've got an interesting case I think will illustrate a number of points and hopefully will generate quite a bit of conversation. I'd love to have the audience as well as the panel involved. I have nothing to disclose. So this case is a 68-year-old male, essentially presented as a STEMI activation. He has a history of reflux disease, and his history was somewhat confusing. He likened it to a lot of heartburn that he's had in the past, but as is often the case, there were some different characteristics of the quality of the pain. It also complicated understanding the duration of the symptoms because, again, he seemed to have some symptoms for a number of days but had clearly worsened the day of presentation. His past medical histories involves smoking and some mild lung disease as well as hypertension. Here's his ECG, not too dissimilar from the previous ECG, but was obviously consistent with a inferior infarct, and again, fairly similar to the previous ECG, but we would conclude this was probably an RCA based upon its overall characteristics. So he was taken directly to the cath lab from the emergency department. You can see the first picture that's playing on the left. He had TIMI-3 flow. Under the clinical circumstances, that was felt to probably represent thrombus in the mid-vessel, although there is some calcification you could see on fluoroscopy throughout the vessel, so the possibility that that may be a calcified nodule or just calcification of some sort is also present. I think because of the clinical presentation, however, he was treated in a fairly expeditious way with just balloons. There were some extra balloons that were used in order to deliver the stent. It's a long stent, a 3.0 by 38 stent, which was placed. You see that in the top right about where it was placed. And then it was post-dilated with a 3.0 NC balloon. And here was the final result, which was judged to be acceptable. And what subsequently happened was, so they had shot the right coronary artery first, had not shot the left coronary tree, so they were moving to shoot the left coronary tree, and in the 2 minutes that it took to do that, the patient had re-elevation of his ST segments, began to have chest pain again. Yeah.
So, do you mind going back to the first angiogram? There seems to be an anomalous circ with thrombotic occlusion coming off the prox RCA. And do you think this had anything to do with the posterior ST elevations? We don't know how big it is. It doesn't look huge, but it's definitely there.
It is there. Yeah, it's a great pickup. I don't have the pictures to show you of the left. Most of the circ was coming off of the left main. This was essentially kind of a high OM distribution. And when you see it playing in the other views, I don't think it was a thrombotic occlusion there, but that's a great point.
So Tim, really important thing. So this is inferior STEMI, and I agree that the anomalous circ part looks a little bit thrombotic, but this is a very thrombotic lesion. When the patient got to the cath lab, what was on board?
Okay, so our protocol currently is they get 4,000 of heparin, unfractionated heparin in the emergency department, and then this was a radial cath, so he got additional heparin in the cocktail. He's about a 70 kilogram person. He got 5,000 of heparin in the cocktail. So the heparin in the ED was maybe 20 minutes before arrival, and then he got 5,000. So he had a total of 9,000 roughly in a 70 kilo person within 20 minutes. And then he got loaded with clopidogrel, 600 milligrams on the table.
So how long before that clopidogrel has any effect?
Hours.
12, maybe 18. So you're doing this really thrombotic case with no antiplatelet therapy.
Aspirin.
Like you said,
and
no.
This is a really interesting one now because there was just a Sky document about STEMI, and I've done regional STEMI centers. I think the mainstay of this regional STEMI system is having P2Y12 inhibitor on board as soon as possible.
Yes.
And because even with ticagrelor, crushed ticagrelor, you have at least 6 hours before you have antiplatelet therapy. And so that works in most of the cases just because they're not this thrombotic. But personally, I think if you have a case like this, very thrombotic, and also in the AV circ, this is one where you have to strongly think about IV. You have to think about canglor.
Okay.
And personally, because this is a setup for acute stent thrombosis, I think.
Was the ACT therapeutic?
Okay, so the ACT after 9,000 of heparin, we'll say, was actually only about 205. That was obtained fairly early in the case, so additional heparin was given. An additional 3,000 of heparin was given. There were subsequent ACTs. We actually had trouble getting his ACT up. He ended up getting a total of 16,000 of heparin, and that gave us an ACT around 255, 260. So
maybe you have a bad batch of heparin, thrombotic environment, a clopidogrel instead of a more potent P2Y12 inhibitor, and also just given before the procedure. Maybe low flow state from this STEMI. So there are multiple factors that trigger this stent thrombosis probably.
And any imaging after stent deployment? I mean, looking at where your stent is in that top right panel, it looks to me like you're into the lesion. So proximal edge dissections, feasible as the etiology as well.
So I definitely would agree with.
I have a question here for Tim. You were talking about antiplatelets. When do you give the clopidogrel? Before you took the angiogram? After you took the angiogram?
Usually, in a STEMI case, we kind of give it as soon as they're in the room.
Yeah.
So, but it's not given in the ED.
Yeah, that also affects your ability to give canglor, right?
No,
no, it wouldn't. No.
Okay, so that's a super great question for out there. So if you've given Plavix doesn't interfere with canglor. Canglor is going to have an immediate effect right away. What you do have to do is, if you've given pre-treated with ticagrelor and then you give canglor, you do not have to repeat the pre-treatment. But with Plavix and prasugrel, you have to repeat the you have to repeat the bolus at the end because you're going to have a little gap. So there's an advantage, and most STEMI networks, most large STEMI networks in the United States now pre-treat with ticagrelor because prasugrel has a red box warning and everything. But I just can't emphasize enough, I think I've seen a shift in the last few years that we forgot about antiplatelets. And platelets are critical to what we do here.
And might ask the panel, you mentioned cangrelor versus 2B3A.
I was going to mention,
people do
don't
that?
forget about the G2 glycoprotein inhibitors. I mean, especially going radially, you're not going to have any access site bleeding there, so you might as well just load them up. I mean, even the heparin, you can go up front with a larger dose. So, I mean, I would not have hesitated seeing such a large thrombus burden here to go big and go home.
Yeah, I mean, there's a lot of hospitals that do not carry cangrelor, so that was going to make a comment. I mean, even if you give a short interval, short duration 2B3A with boluses, I think there's a question from...
Vlad, do you have a comment?
Yeah, so we know that as much as 9,000 heparin was given, but how big was the patient? I guess
70 kilos.
Okay, so you have to wonder about your access, your intravenous access as well, unless you're given this intra-arterially. If you're having such a poor response. We don't have cangrelor actually in Canada yet, so I would, in this situation, give integralin immediately, and that gives you also immediate antiplatelet effect. So.
Okay. Any other thoughts before I...
One more question. So it was an RCA infarct, right? And some people would go shoot the left first, then go to the right. Just as curious on the thoughts, who would go straight for the culprit versus the left?
Yeah, I mean, personally, my practice, if it's an RCA infarct, is I like to shoot the non-culprit first because, there can be so much in the left main or, the left tree that might change how I do things. If I think it's a left-sided infarct, I usually won't take time to shoot the right coronary first. But how do you guys proceed?
Before I went radial for most of my STEMIs, I used to shoot the non-infarct, what I thought was the non-infarct first, and then while I'm getting equipment, then shoot the right. But now that I usually go up with the JR for radials universally, so I'm always shooting the right coronary first and then shooting the left. It doesn't matter what you think that the infarct artery is.
We've also used the Ikari guides that you can shoot both coronaries with the same one. I like that for infarcts. It's not incredibly supportive, but for an infarct that you don't typically need a lot of support, that can be a great option as well.
I think we're focused a lot on the pharmacology, but the other question that really comes to mind is the age-old question of, thrombectomy versus no thrombectomy. And the other big question is, was imaging done? Was usually when there's acute stent thrombosis in the setting of an ACS or even otherwise, there's often a mechanical issue. I'm not saying that there was an edge dissection, but oftentimes the setup is manifest by an under-deployed stent. And although that right does not look like it could very well be a 4.5 millimeter right coronary, which got a 3 millimeter stent. So go ahead.
I was going to say, if I can have my slides back, I'll show you. So they did not do imaging prior to the thrombosis, but then afterwards they did do some imaging. So first thing they did was just went back in, it was occluded, they wired it, they ballooned it to restore flow. What you're seeing here is really just about the proximal third of the stent and then proximal to the stent. This is the area proximal to the stent. There is probably a dissection there as well as a lot of untreated disease, and then the proximal vessel there is kind of the true proximal reference. So this is, again, stented area that's pitifully underexpanded. And then, so you have multiple things. I mean, I've got it all. We've got an underexpanded stent, we got a proximal untreated area, a proximal dissection, and so the IVUS was very helpful. There's the proximal reference size, which is 10.5. You can see a dissection, and then on the right-hand side are just two snippets of areas of the stent that are fairly small, about 5 square millimeters. And so this was treated with further balloon dilatation, just with NCs and high-pressure balloons. No IVL was done at this time. An additional stent on the proximal, as you pointed out, was necessary. We did escalate the heparin, so the additional heparin was given although we only achieved an ACT of around 250, we gave over 200 units per kilogram, which is, a lot of heparin. We did give integralin double bolus instead of the cangrelor. We have both available, but they opted to use integralin. And so this was really a case of there was pharmacologic issues that were probably not optimized, as well as there were technical issues which were not optimized in the beginning. And in intravascular imaging, you certainly could argue would have changed the way the initial procedure would have been done. And so here's the final picture. That one's not playing, but it looks good. And, oh, there it is. And you can see up by that first marginal branch the additional stent, and that was the area that probably was untreated. And so just as kind of an algorithm, I'll run through this in 45 seconds, and then we have a couple of minutes for discussion. When you have acute vessel closure, I'm going to call no flow. My fellows a lot of times will say no reflow, and I kind of like to reserve that for more of a microvascular issue. But anytime you have vessel closure, I think the first things that you should be thinking about is your anticoagulation and your antiplatelets. Not only do you have something on board, but is it adequate, and is it adequate for the scenario? What may be adequate for treating stable coronary artery disease might need to be escalated, as you were pointing out, for somebody who's in a thrombotic milieu and they're just highly hypercoagulable. So antiplatelet options, they needed to be more aggressive, number one, and then probably needed IV options. For those that have no reflow, which is really a diagnosis of exclusion, the treatment, just as a reminder, is pharmacologic and not so much nitroglycerin, but things that work at a capillary level. In our lab, we typically use calcium channel blockers and adenosine, but certainly in a situation where you have hypotension, epinephrine can be used. For those that really have a technical issue, a macrovascular issue, you're usually going to start with PTCA to restore flow and help you see what's going on. Intravascular imaging, so important, as this case illustrates. And we've seen a case of dissection. This had some dissection. It had underexpansion. It had geographic miss. Not so much, I don't think, thrombus and embolization. I think actually what we saw in that first picture was mostly calcification. But again, you get fooled in the situation of a STEMI, and you can easily mistake it for thrombus. But in that situation, you'd consider aspiration, vasodilators, antiplatelets, and then additional stenting. So with that, any other comments?
Just a couple of things. One is, great case, but in cases that have no flow, I think, of course, you have to open the vessel. But if you have flow, I think, I think there's an opportunity to do, if possible, imaging up front, because that way you choose the biggest stent possible, if able, get by with direct stenting, and also minimize the post-dilatations. I feel that sometimes if you undersize, you don't image, you image later, now you post still 3-4 times, it becomes a vicious cycle, no reflow. And something that I'm interested in Tim's thoughts, since I know he's done a lot of work on this, is whether in the cases like this, I know we've done supersaturated oxygen mostly for anterior, but in this big dominant RCA thrombotic microvascular, you think there's a potential role in the future for supersaturated oxygen here?
There's a couple different questions in there. I want to start with this. This is an antiplatelet problem, and people can't forget. In STEMI, antiplatelet is a key part of what we do, and we know data from very clear that prasugrel and ticagrelor cut stent thrombosis in half compared to Plavix. No role for Plavix in STEMI in America. No role. Second, in pre-treatment, I know there's a little controversy about it recently. All the large STEMI systems that I know in the United States, you do pre-treatment as soon as possible, and the guidelines say as soon as possible. We've published already that the patients that transferred in have almost no stent thrombosis. All stent thrombosis occurs in the first 6 hours. And if you get there fast, so a lot in Cincinnati now, we pre-activate. So we have many patients who are literally on our cath lab and we're dilating within 15 minutes. That group of people has no antiplatelet on board. You have to really consider, and if it's a thrombotic lesion, we use cangrelor. Lots of places do use cangrelor 100%. We don't, but we pre-treat. But you have to have adequate antiplatelet on board when you do a STEMI, period. And so I think it's important. I think there might it might be exacerbated by underexpansion or tiny edge dissection. For sure, that can make it worse. Then the other issue is large infarcts. And this is, I think, where we're going with STEMI, and it's too long, this will have to come, is I think we have to identify large infarcts on the play table, and the patients who have microvascular obstruction, there's ways we can identify acutely, and that's a group we should think about SSO, but maybe we'll get to that later.
Yeah. Terrific. Let's try to keep us on time. Our next speaker is Saroj Neupane from Banner University. Is going to be talking about aortocoronary dissection.
Hi, good morning, everyone. Can I have a slide, please? I have no relevant disclosures for this talk. Case I'm going to talk about is 67-year-old guy, history of hypertension and hyperlipidemia, had a diagnostic cath for angina. You can see it's very obvious, right coronary artery CTO. He's already on 2 anti-anginals. Those are the left system. There is a moderate to severe disease in the LAD that was further evaluated by hemodynamic testing and not significant despite supplying collaterals to the RCA. And then there is also occluded circ. So he was referred for CTO PCIs. He has 2 vessel CTOs and already on anti-anginals, fairly active prior to the recent onset of angina. So I brought him to the lab to do a CTO of circ first, and we attempted to integrate wiring, which you see on the left plane. That failed and ended up somewhere not in the actual true artery. Therefore, we decided to go a retrograde, which that's an epicardial collateral from diag easily into the distal vessel. We attempted retrograde wire escalation, but the wire ended up in subintimal space, so needed to do a reverse cart. And I decided to bring a ping pong guide with getting another access. Any questions so far? Since my talk is about aortocoronary dissection, so you can probably guess what happened next. You see 2 guides. We have a safety wire actually from both guides. One of them is in a proximal diag. Normally, we try not to take pictures because I knew the circumflex was occluded, but when I had the second guide up, the patient with only 1 open vessel, his ejection fraction fortunately was normal, started complaining of chest pain, blood pressure started trending down, not like in 80s, but it started with 140s and down to 110. So had to take a picture at that point and obviously clear findings and explanation for his chest pain. So thoughts, comments?
You know, at this point, I would not potentially even do any more angiography and be thinking about potentially impella ECMO activation. This patient needs to potentially support right away. And what I feel happy about this case is that you have the wires. I've seen some M&Ms about this without wires. Here, at least, you have the wires.
Yeah, excellent point. Yeah, you do not want to inject at this point. We are lucky. We have a guide catheter, actually 2, and both of them with safety wire down there. You see the second wire is not in the true LAD, it's somewhere in the distal branch, but you know there's in the true lumen, at least in the proximal LAD.
So was it the side hole guide, or was it?
No, both of them. I almost never use the side hole guides for the left system, so both of them are non-side hole guides. And
so here you got a big problem, and of course all the things that were mentioned so far are pertinent, like activate ECMO, impella, prepare, anesthesiology, cardiothoracic surgery. But this does not happen like in a video game immediately, right? So I think that the most important thing to stabilize the situation here, at least try, is to drop a stent in the left main ceiling, the aortic flap. But you have a problem here because you have 2 guides and 1 wire is almost externalized, right? So you got to pull that out real quick and stand on the LAD wire, I would say, because it's the only open vessel.
Yeah, so what Lorenzo was trying to say is almost externalized wire. You don't want to, you want to cover that with a microcatheter. Just don't pull the retrograde towards your epicardial, because you can slice the collateral and you might create another problem. So, like I said, despite...
One quick question.
Yeah.
So right now, how's the patient?
So, like I said, blood pressure 110, chest pain, ST elevation anteriorly, but he has been relatively stable, just pain.
So here's when you have wires, take a deep breath, get someone else in to help. So right now is a good time, if a patient's stable, get someone in, because it may be you need to be doing multiple things at the same time. And this is a time to, if you have the minute, get someone in, including maybe an echo tech too, because this is nasty. Can you go back to the first picture first? The other thing is, take time and think can you run that? Yeah, there you go. So you have to decide what's the most important part here and where you're going to go first. And the patient's stable, blood pressure is 110, you have a chance. Think really carefully about what your strategy is, because the strategy depends on what you think is most important to revascularize first. And so this is a moment, if you have a moment, you might not, because his pressure's 50 and you have to just do it. But if you have the chance, bring someone else in, look at it together and say, what's our plan going to be? And think about that ahead of time. You've got wires, so you have a middle time.
Yeah, so all excellent points. So a couple of caveats. So like Lorenzo mentioned, first, he's relatively stable. So the first thought was to just put in a stent, seal the dissection, and then see if it stabilizes. But there is an almost externalized wire, so you do not want to trap that. So you have to figure that out. That's one of the challenges. Another one is your second wire is in a branch on the second diagonal. So you want to make sure that your stent doesn't extend past, and you don't want to extend into the smaller diag. So that's another challenge. Again, I don't know how, but he is stable. But I had suspected, because he started complaining of chest pain maybe 30 seconds before I took this picture, so I had asked for a long 3-5 stent and in the room, basically. I was able to advance the microcatheter, and so basically we kind of talked about this. This is, I'm going to skip through, and previous speaker also covered all that, and we can come back to that. So I was able to redirect the wire from the diagonal into the apical LAD, put in a 3.5/24 megatron stent, which is kind of nice tool to have. You know, you can expand up to 6 millimeters, so you don't really have to worry about the size in emergent situation like this. And you see the picture on the right side, the dissection has extended into the cusp, and there wasn't a great flow, so I added a second stent, especially considering the mid-LAD lesion, little longer, covering all that. A good flow in the LAD, so it is dissected, which we expected. After that, he quickly stabilized, and then he is stable now, no chest pain, ST changes resolved. You watch him in the lab, do any other testing.
So I think very important here when you have our aortocoronary dissection to make sure that the stent is well opposed and protrudes into the aorta. So I would image, but most likely I'll still flash it to oppose the stent to the aortic wall and seal forever this inflow in the dissection.
After he stabilized, we did IVUS and post-deal and make sure the stent is opposed, and we covered the ostium, and it was covered. Yep. Anybody would do CTA here after, because it was extending into the aorta?
Yeah, that was my point. We had a case similar to this a few months ago, and it's just you need to know the extent of the dissection into the aorta. Have your surgeon be involved in the case looking at it, and also, even if the hemodynamic is stable, what do you
Yeah, so I was concerned about that, especially the aortic hematoma, and you see a little bit of shadowing in the cusp also, even after the stent. Did do a CTA. There was a small intramural hematoma in the left sinus. We watched him for 2 days, no progression of symptoms, and was discharged home. He was gracious enough to give me another opportunity, and I treated his RCA CTO as well as SARC CTO, and fortunately those procedures were uneventful. So I want to show a couple of other cases. These can be very subtle also. This is a case of RCA.
Sorry, one question here, one second.
I think one of the challenge when you do epicardial is also there's always perforation. One of your pictures showed diagonal had a perforation there. There was contrast, but you said you had a CT scan.
Yeah, we also had a post-op echo, mostly for EF, and there was no effusion, so
okay.
Probably just
just sealed it up.
Yeah. These can be very subtle. This was the RCA CTO stented from distal to proximal segment. There is no lesion in the proximal segment, but if you look at it, there is a dissection extending back into the aorta, maybe minimal dye hang up on the fluoro, but clear dissection migrating up to the aorta and IVUS. Added a 12 millimeter stent, a little bit of dye hang up. These case, when you have just a little bit of dye hang up, I didn't think we needed a CTA. We didn't do a CTA. It was 24 hours, no eventful, and hospital course and discharge home. The another example I have is you can see the PCI we were trying to do PCI, the distal RCA stent was put in, and there was a cusp dissection. Anybody would leave this and not stent the ostium?
I mean, I usually think there's an entry flap into it, so that's unstable. So I think I would certainly stent it.
Yeah, that's what we were always taught to, but I actually, just to prepare for this talk, I did some literature review, and there are several algorithms, say medical management and wait and watch, so which I was surprised to see, and this was also not stented, and 2 hours later, this patient had chest pain with some neuro symptoms, so went for emergent CTA, and dissection was progressed to the arch as well as a major vessel, and I had to have emergent surgery with aortic root repair. So we should never be leaving this alone, and even after you cover the ostium, and when you stent, you obviously your goal is to treat the inflow of the dissection, but if you are not sure about the inflow, even with the IVUS, just make sure you cover the ostium. So a couple of comments. Obviously, it can be rare, but potentially fatal at the same time. And you have to be extremely careful when you are using two guides like ping pong, or it can be common than usual, especially you are manipulating retrograde gear. It's almost always catheter induced. For whatever reason, RCA is more prone, and then most common cause is obviously vessel closure, MI, and death. But even if they are stable, the other concern is retrograde progression to the aortic arch. So we have to make sure that you don't have a hematoma more than 4 centimeter in the aorta. So this is the classification. So if you have 1 and 2, you treat conservatively after stenting, and if you have 3, they did emergent surgery. Thank you.
All right, we're at time, but I'm going to just ask how many in here would do a CT of the aorta? And how many would keep the patient in the hospital at least 48 hours? Yeah, I think it's prudent. This is really hard, and it's really unpredictable about who gets worse or who doesn't, but good cases and a really good point. But we need to move on. Our next speaker is Vlad Dzavik from Toronto, who's going to talk to us about I lost the branch algorithm.
Thank you very much, Tim and colleagues. Happened a few times, I'm sure, to all of us, and I'll show a couple of cases, at least the beginnings of the cases, invite some discussion, and then we'll go through the algorithm and show you the resolution afterwards. So this is the first case, 79-year-old lady. Okay, thank you. 79-year-old lady. Did everybody hear the first parts of what I... Anyway. 79-year-old lady with CCS, class 3 angina, LAD CTO, and we were, as you can see, a dominant circ, not much in terms of collaterals coming from the right coronary, so most of them were intracoronary, as you'll see. And we also had this proximal circumflex lesion, okay, which we're going to fix first en route to doing the CTO. So here's some imaging of that, just showing that it is truly a significant lesion. So we demonstrated that, and we pre-dilated this large dominant circumflex vessel. We stented it, and then had this. So if we go back, if we go back to that, maybe I can just leave you with this for a minute and ask your thoughts as to what you might do in this case.
What was the, I guess my thinking is, you're going to do a pretty complicated CTO of the LAD. Like, why start off and, make it so you're obligated to DAPT right out of the gate?
Well, it is it's a large dominant vessel. The RCI didn't show, but it's very small, and I want to make sure that, foolishly perhaps, that I wanted this to be perfectly stable and not cause any trouble during recanalization of the LAD itself. So that was my perhaps faulty logic, but it is what it was. And we also used, I guess, views that perhaps didn't. In some views, you can see the origin of that OM, and it's a large OM. It's definitely, I think, an OM that supplies a significant portion of the myocardium. And we missed that. We missed actually protecting it. So the OM was not protected, and so we ended up with this result, and the patient's having ST elevation we have 3 leads on our monitor. AVL is one of them, so AVL, ST elevation, and a great result in the circ, okay? Wonderful result in the circ. A 3/5/20 drug-eluting stent was deployed, and an amazing result. So what to do now? And we don't see the side branch at all.
I mean, I think that's going to go back to the first case we saw. The difference here is that on the diagnostic pictures, that ostial OM had disease. I mean, to me, it looked like it had significant disease. Again, I am very cautious with side branches. I would have wired it, probably even ballooned it, and saw how it looked like after you balloon the circ, and then decide whether you want to do further than that. So I guess here you're left with what we did in the first case, try to recanalize that OM without perforating the coronary sinus, hopefully.
Yes.
It also looked like it was inflow to your LAD collaterals too, which, is certainly going to complicate the ischemic burden here.
Yeah.
So
and she definitely had ischemia. So, and any other thoughts?
Another point here is sometimes when you do a really good job on the main vessel, like here, you did a beautiful result, that's when you're actually more likely to lose the side branch. Or sometimes accepting maybe a less optimal result might reduce a little bit your risk of losing the side branch. But again, it can happen to anyone, as you said, and now it's time to get through it.
So I'll show this to you later, the resolution, but here's the next case. 87-year-old lady, exertional dyspnea was her symptom. She had ischemia in multiple territories, went on to coronary angiography, was found to have 3-vessel disease, and this is what her left looked like. Again, the right was a small vessel. I'm not showing you this. and not really relevant to this. And she also needed surgery, major orthopedic surgery, which is the entire reason why she had the ischemic workup, because of her exertional shortness of breath. So we pre-dilated the LAD, and here is our IVUS of both the LAD and left main, LAD to left main and circ to left main. I'll just let this play for a minute. So we have the circ protected and with a wire, and I guess the question is, would you do anything else with this? And I'm seeing some nodding of heads that yes.
That was my question.
Well, I think that's why I'm showing the IVUS, and that's the question.
I mean, to me, it looks like the osteocirc has a focal, like right there, severe disease. Just when you start seeing two wires,
yeah,
it looked like the osteocirc has like either a napkin ring or a focal lesion that we just don't appreciate on angiography. So I would at least think of a two-stent technique here.
Well, I would at least case and see how it reacts.
You would what? I'm sorry?
After you dilate, I just take a picture and see if there's been any compromise of the circ or what everything looks like, and make a plan. And this could go either way.
So these IVUS pictures are actually after the pre-dilatation of the LAD. Okay.
Yeah, but both the spider view showed high-grade stenosis, and really the IVUS shows high-grade stenosis, at least at the ostium of the circ.
Yeah. So I think the presence of a 1-1-1 bifurcation doesn't necessarily mandate a two-stent procedure, right? Unless it's a definition complex procedure, which I'll describe in a little bit. So that was my thinking, but there are other things you can do, and they were not done. So we pre-dilated with a 375/15 NC balloon and then deployed a 3.5/18 stent. And this is the attempt to rewire. The circumflex was unsuccessful at this point. And I immediately called anesthesia, and they helped with hemodynamic management, which she settled with appropriate pressor therapy at that point. And I'm unable to get a wire into the circ at this point.
Do you ever jail wires? Would you have considered jailing either of those cases?
There is a jailed wire there.
In the previous one?
Yeah.
As well?
There's a jailed wire here.
Okay, in the previous case as well?
No. That was a oversight.
How do you decide
I fully admit.
Whether to jail or not jail?
Well, I generally, almost virtually always jail. Okay, so the previous case, I can't answer that, and it was stupidity, basically. Okay, so fully admit that in the previous case, that side branch should have been not just wired, but it was a complex, long stenosis. It should have been treated up front. Okay, but we're on this case, and there is a jailed wire here, but I still can't rewire it at this point.
So here, after dealing with blood pressure, whatever you have to do, Impala, inotrope vasopressors, you have the wires, so I think now you can do a dual lumen to try to get polymer jacket. It escalates, Fielder XT, Xeon Black, and also even an angulated microcatheter. But what did you try here?
Is there a chance? That you can pass through the wire you have in the circumflex. You can pass a small balloon and just open up underneath the stent.
Those are all great ideas, and I'll show you how we did this, and that certainly is both are part of the algorithm. So the algorithm for the lost side branch, most importantly, is to prevent it. So prevention is key. Prevent the occlusion. How do we do this? We plan using intravascular imaging. to assess the risk of the occlusion. Calcium is a big thing, which we often don't see with angiography. And so essentially, that is what we have to deal with as well, with modification, if need be, if it's severe calcium right at the bifurcation. There are scoring systems that have been published for lesions that you're planning to do a provisional stenting strategy for. This is one that was published recently, and this group actually did a previous one for non-left mains. This is left mains, very straightforward, angiographically determined criteria, plaque distribution, is it ipsilateral to the side branch? If that gets, if it's contralateral to the side branch, that gets a lot of points. Diameter ratio between the main vessel side branch and baseline side branch diameter stenosis percent, so you can see the different values there. So what they determined through their study was that if you had a risk score of greater than or equal to 8, based on these, that your side branch occlusion was significantly different. So these are simpler things that you can use even if you're not using intravascular imaging, which you have access to, you should use for more accurate assessment. Wire the side branch, that was mentioned, and that I think is pretty much universal for me in all things where I don't forget to do it, which is rare, but because that bifurcation is a big thing for me. So wire the side branch, a very great point that was raised. What about pre-dilating the side branch as a strategy? So I think the European Bifurcation Club published guidelines, recommendations not that long ago, 3 years ago, and here's where they would recommend pre-dilating the side branch if it's a definition complex lesion, so if it has a side branch stenosis greater than 90, long lesion length greater than 10 millimeters, severe calcification, or bifurcation angle greater than 70 degrees, they would recommend pre-dilating the lesion. And so I'm doing that more and more. If it's a simple bifurcation, it's probably not necessary. In this case, we didn't do it. I would have classified that as a simple bifurcation as opposed to a definition complex bifurcation, and maybe I'm wrong about that. So ballooning ballooning or balloon in the side branch is another possible technique. If you think you have a higher risk bifurcation, you actually leave a balloon under the struts of your main vessel stent. And there are a couple of studies that suggest that that's feasible and efficacious, though reports suggest that in left main bifurcations, that could actually be risky, so I don't do this in left main bifurcations. Finally, treating the occlusion, rewire the side branch, which we tried to do here, not always possible, and various techniques you can use. The dual-lumen catheter that was mentioned, proximal optimization technique, where you actually, one of the reasons you can't get into the side branch because the main vessel portion, so for example, in this case, the left main portion of the stent is undersized and it's actually not opposed. So if you proximally optimized, you actually improve the angle if you do it in the right position so that the shoulder of the balloon actually sits right at the bifurcation. So you're actually improving the angle of re-entry into the side branch. IVUS or OCT to actually find the branch, which we had to do in this case because we didn't see at all where the entry point was. Dual-lumen catheters, angled microcatheters, and finally subintimal tracking, reentry or STAR, a CTO technique, can be used if nothing else has worked to get into this and to open the side branch. This is what that looks like. As you can see, so this was a described technique for stent-jailed side branch inclusion by Mauricio and colleagues, published a couple of years ago. So finally, back to the cases. Case number 1, severe chest pain, ST elevation. Case number 2, hemodynamic collapse. So case number 1, we tried dual-lumen catheters. We could not get a wire into it. We eventually used IVUS to actually find the entry, and then used a Supercross 90, an angled microcatheter, which gave us the support to get a fielder XT in. We then were able to get the microcatheter into the side branch, Xion blue, then exchanged to a wiggle wire, and finally did a reverse crush, which looked like this. That's before the crush. You can see the balloon in the distal vessel before the crush, and then about ready to crush. Then the crush, and then we actually did a proper re-entry into the side branch, kissing balloon inflation, pot, etc. You're seeing this because this is the image 7 weeks later when we actually brought her back to fix the LAD, and there's the open LAD, and there is the OCT image of the result of our reverse crush 7 weeks later. Case 2, pot with a 4.5 by 8 millimeter NC balloon. This actually didn't improve flow, but markedly improved access to the side branch. There would have been other things we could have done, including what Mauricio had suggested. Had this not worked, rewired easily, 2.5 by 50 millimeter NC balloon. We then had a nice balloon result after kissing balloon inflation. So we decided at this point to treat this with a drug-coated balloon, a Pantera Lux, and a final kiss. And then that's the Pantera Lux. And this is our final result, and the IVUS of from the LAD to left main in this case, and then from the circ to left main in the second one, which is right here.
We've got time. We got to move on to our final speaker here.
Yeah.
But, thanks. If
So
we can wrap up.
the majority of side branch occlusions can be prevented with thorough assessment, lesion preparation. The relevant side branch should always be wired with pre-dilatation and possible placement of a side branch balloon in high-risk cases. Knowledge of technique, tools needed to recanalize is essential. Thank you.
Thank you. Our final speaker of the session is Dr. Spaedy from University of Kansas, who's going to present his worst vessel occlusion case.
Okay, thank you. Yeah, so I have a confession. This isn't really my worst one, but I think it has good teaching points, and it is a good case. So we'll show it. I also congratulate the cases. It's hard to show your complications. It's easy to try to hide them, and there's always something we do different when we show a complication that you feel kind of silly about in retrospect. So I think this is good for all of us to learn, especially these sometimes when we don't wire both vessels. So this is actually what seemed like at the time a very bread and butter basic case. A young lady, she's young now, then I'm 61, but she's 61 years old, not much medical history, except she's a smoker, and comes in with recent onset, pretty classic angina. The pain goes away in the emergency room. Her EKG shows inferior ST inversions, no elevation. Her troponin is significantly elevated already. She gets recurrent pain. We had actually seen her in the emergency room, and this is just a kind of a regular case, and so she was moved up in the cath lab ahead of schedule and taken to the lab. We didn't preload her with antiplatelet. We do, I agree, 100%, I think, all ST elevations, but we don't tend to do the ST depressions or the inversions because a lot of them go to surgery. But anyway, so this, to me, you know, if you looked at it, you would say this could not go wrong, really. It's her left system's almost normal. There's no collaterals to the right. She has an eccentric right coronary lesion, kind of a high bifurcation of her LAD, I'm sorry, of her PDA and PLB, which will be pertinent in this case. Her right has a little bit of an angle proximally, so you see a little tinting from the Tiger catheter. It looks very eccentric in this case, or in this projection in the RAO. So this was just attempted to be wired kind of as a regular case with a workhorse wire, a Pro Water. Interestingly, the wire immediately, this is probably a very soft lesion, maybe there's a little dissection that we didn't appreciate or something, but the wire immediately just goes into the wall each time. It seems to go either right or left, but it just hangs up once the knuckle This is a very gentle workhorse pro water type, spring-loaded wire that you really think is pretty darn safe. But here, while this is being attempted and not going as easy as it looks, she develops severe chest pain. She's a very anxious lady to start with, and it becomes a much more challenging case for everyone because she's pretty animated during the case, and she gets tachycardic maybe because of stress, but otherwise pretty stable. But her STs go up substantially. A little puff of dye. The wire's back now. It wasn't going anywhere anyway. So this is probably not a huge surprise with what I told you. I think the diagnosis is probably pretty straightforward from what we've been seeing. Go ahead.
Would you, call anesthesia, or would you give nitro? What would you do in addition to trying to rewire this?
Yeah, so we did not give any nitro, but we did notify the surgeons, and we had 2 OR suites going with pretty active cases that weren't close to finishing. So surgery is really not an option, at least in the immediate future. We did not see any collaterals coming from the left, and so we thought we hadn't really tried much more aggressive. But assuming on this case that you tried additional things and you just cannot get a wire, usually I would say when you have a abrupt closure like this, this looks like we've got some subintimal injury. We close the vessel completely. She's ischemic. Usually seems like 90% of the time, maybe more. If you try different wires, you're just stubborn. You're going to get it wired in the true lumen most of the time. But this one wouldn't go.
Yeah, my point was speaking to your point that she was a very anxious lady, how much of this is spasm, and therefore anesthesia for propofol, not necessarily to go into the OR, in addition to nitroglycerin.
Yeah, we just gave her some more sedation, kind of got her to sleep. We didn't get anesthesia, but I think that's a great point. We had to get her calmed down. But I think it changed the intensity of the room, but probably didn't change the decision. So our feeling is this is just a wire that probably contributed to a dissection, closed the vessel, and then what can we do to get out of this, assuming we can't wire it and surgery's not available. And I've heard most of these things brought up already from previous talks. I mean, you could put a guide in the left and try to go retrograde, and that sometimes sounds like a better idea, especially if you saw a hint of collaterals to start with. This lady, it wasn't that terrible of a lesion. I was a little skeptical that we would have she didn't have any big septals first, and the septals, they just didn't look like classic retrograde septals, even though you can occasionally get through when you don't see a collateral. The second thing is stingray this vessel. I think this will be a very tough stingray case. You could do this, but you're going to have trouble imaging.
What was your wiring mode of failure?
So there were a couple workhorse wires tried, and then we kind of escalated to some more of the CTO algorithm wires. We tried an XT to just see if we could find a tiny little lumen. We used a microcatheter so we could exchange the wires quickly and not have to do everything. And but it was pretty clear it wasn't going to go easily.
Did you ever get subintimal and feel like you were going around the lesion though?
So that's what we did. So we did. It was clearly going subintimal with everything we tried, and it seemed like we were going subintimal on both sides of the vessel. So we decided, there is a high bifurcation. This looked like a reasonable case to consider starring. So we kind of went over the answers to these questions, but it looks like an abrupt closure from dissection, and it can happen with your most gentle wires. Very uncommon, but it can. And so this is the Gladius Mongo, which you can use about anything to star, or a lot of wires anyway, but this is a classic one that's really built for starring because just the tip of it tends to curl very gently. It's a 3-gram wire, but it knuckles easily. So you can see we switched guides. We got an AL to give a little support. We got a guide liner in there and a microcatheter. You can see we're pushing fairly good on the Mongo, but we bring our guide liner down and our microcatheter down, which gives you a little more support. And then you see the knuckle forms, push a little harder, and the knuckle jumps forward here. Right there. So when that happens, you know at least you're fully subintimal. The question is, did it jump true lumen or not? You're hoping it jumped true lumen. The bifurcation's only about another 1.5 centimeters, or at the most. It's not very far from that. And typically these jump true lumen at the bifurcation. So we use a lot of support. The other thing the guideliner can help you with, not just support, but it decreases the hydraulic force. So you want to not be injecting dye so that you don't cause a further hydraulic dissection. And then bring down your guideliner, which decreases the flow into the vessel, so you have less likelihood to get a big hematoma. And then when the knuckle jumps forward, if it enters the true lumen, it tends to do it at a bifurcation, and you can watch the knuckle as you push it further and hope it gets smaller. If it gets bigger and goes somewhere strange, you're kind of got a problem. But most of the time, it'll constrain as it's in the vessel, and the vessel gets smaller, the knuckle gets smaller. So you're hoping it gets smaller, and I think this one, you see it's pretty big here. We push it forward. See how the knuckle gets very small as it goes into a branch. It's constrained by the true lumen of the branch. So we feel pretty good about it. We do a really tiny injection here. You can see we've got flow in both, so it probably did break at the true lumen. And then at this point, we brought a second wire down, wired the posterior lateral branch, and then we ultrasounded this, and it was interesting. The dissection does in the bigger branch, the posterior lateral. We don't see any. It looks like it entered pretty nicely there, so it looked like it was a friendly one. Usually we don't stent star cases because you tend to shear off a branch or lose. They don't have as good of outcomes. But this one was pretty short. And by ultrasound, I thought there was probably a little tiny plaque in the posterior descending at its ostium, but we did go ahead in this one and placed a 15 millimeter stent after ultrasound, and she had good flow and did fine. You see a bit of a step up proximally. And this is about a 2.5-year-old case, and she has continued to do very well. So it is a way, I'd say the star is a great way to get out of trouble, even if you don't stent. If you can get great flow down one, sometimes you can even star the other branch. There's different things. It can get you out of trouble sometimes, and this is a case where everything resolved. Go ahead.
Did you stent into the PL or the PDA?
So we tried to land it, and I can't tell if we're exactly on it, basically at the bifurcation. I put the dot of the stent of the balloon kind of in the PL slightly, but the stent's back, just right there at, or maybe mid marker at it. So we might be microscopically. We did re-ultrasound too, but I couldn't really tell real easily. It looked like it was right at the bifurcation, but there was great flow in both, and I decided not to try to do the bifurcation. You could have either done a 2-stent strategy or not stent at all, let it heal and bring her back. Those would have, I think, both been reasonable options. This is kind of an unusual start where it seemed very short. The IVUS looked very friendly. And so we decided to do that. If anything, the stent may just be microscopically into the PL, and we did not then post-dilate or do a bifurcation kiss at the end, which also would not have been unreasonable. But it looked like the ostium of the posterior descending didn't have much concern.
Great. Any questions or Tony?
Well, I'll let you in, John, but Manos, for this acute vessel closure session, next year let's call it Be Humble, Be Prepared, and Know Your Options.
No, thank you. And I think I could thank everyone because, as you said, this is very hard to solve complications. And all these were amazing cases. I think we all learned a lot. And that's probably the best legacy for a complication for other people to learn so other patients don't have the same problem down the line. So thank you so much.
Terrific. And thanks, everyone.